subtrochanteric femur fractures, a special kind, a special challenge of fractures. The special thing about the subtrochanteric fractures are their biomechanics, and it was already many years ago that Freumpson, he showed the actually what happens to the proximal fragment. It's usually abducted, flexed, and externally rotated. And this is one of the challenges because it can be quite difficult to do a closed reduction on this proximal fragment. The other specialty is that we have a different loading of the implant. If we have an extramedullary implant, we have a load-sharing device which needs a stable fracture reduction and also a good cortical support opposite to the implant. On the other hand, if we have an intramedullary implant, this is load sharing and it can bridge also an unstable fracture. In that respect, it is more versatile. The choice of implants are multifold. The very elegant surgeons still use a 95-degree angle blade plate. You have to have quite some practice to do that, but it is, of course, by far the most appropriate type of fixation for these fractures. Then we have those screw plate combinations, DHS, DCS, etc. The LCPs also go into the category a reversed list can be used. Then we have the nails, the PFN A, PFN, the long one, the gamma nail, and finally also the UFN or recon nails. I think presently there is almost a pendulum that swings a little bit back from the nails to the fixed angled locking plates, which do have quite some advantages. Nevertheless, the nail has some excellent indication and also excellent results. I just show you a few examples. You have many more than I do and are quite familiar with this situation. An unstable trochanteric and subtrochanteric fracture, very often they are elderly people, unreliable, that cannot be off weight bearing for a limited period of time. And I think there is a big, big advantage to use a nail. This is an 85-year-old. We had difficulty controlling the proximal fragment. He needed a cerclage wire for reduction and was left in. The patient did quite well, got up, walked around, but then this is the 18-month follow-up, which with the cerclage wires still in place. This is the patient I wanted to say that also had a cerclage wire. He got up, he was demented, he was suicidal, he walked around, and then finally he died in hospital a few weeks later. And there was one of the first PFNs, long PFNs that we used, and I wanted to know what it looked like. So I had that bone taken out, and I was surprised how little fixation it actually needed to keep this proximal fragments or multi-fragment fracture in situ, and that it would also support full weight bearing. So I think this is one of the big, big advantages of this device. A young chap with a bilateral subtroch fracture, which I fixed as an emergency without exposure. I had no problems I did not struggle to get to the distal fragment as many, many years ago. That was the case here at Harborview. And you see the reduction, it's not perfect. And what's even more amazing is that actually the multifragment fracture healed much quicker than the short transverse fracture, which after 5 months still had some problems here. But this is typical because of the gap. So, are there still indications for subtrochanteric fracture fixation with plates? And I think yes. And I'd like to show you a few cases. This is another young chap. He was a drug addict, had a motor vehicle accident, and this rather shattered femur. And above all, he had an acute compartment syndrome of his thigh. And this is a little later when we could suture the skin finally. And this is the follow-up after 1 year or so. We took off the plate, and he has a fairly good function. One of the things that may be very difficult in those proximal fractures is the reduction in such a way that you can then apply the plate. And I have, from my very early days with Dr. Allgöver, still had in mind one tool which is ideal to reduce such a fracture, and this is the cerclage wire. If in this fracture situation with several longitudinal fragments, you put the cerclage at the right position, you practically can reduce this fracture anatomically. And this is the actual under traction and one cerclage wire. The fracture is anatomically reduced. Now you just have to place your implant. And here again, it was a DCS that was used. This is some intraoperative films, guide wire placement, etc. And this is once more the fracture, and this is after placement of this DCS. There's a slight above here. But the patient was quite cooperative, and this is at 43 weeks later with full integration of the medial cortex and very nice healing of this rather extensive fracture. Multiple injury patients, we have a tendency to do early total care if possible, if ever possible. So in this patient, we started out with the femoral shaft fracture for a nail. Then he had this pelvic ring fracture and a subtroch fracture. And in the same session, we fixed both the subtroch fracture and the femoral shaft fracture while we delayed the other injuries. So this is post-op of the DHS and the nail. And then this is a secondary procedure to repair his forearm and his pelvic ring injury. And here we see the patient about 5 weeks later, and this is at 1 year, fully functional recovery of this quite nicely. Question is indirect reduction and axial alignment or direct anatomical reduction. Are those the choices? I think if we have a simple fracture, type A or B, which can be reduced anatomically, we should strive to do so with lag screws and then a neutralization or a protection plate. And this is such a case because I think on the long run they do better than the bridge one, especially if we want to keep the correct angles of the proximal femur. There is this very nice paper from Kinas, Bollhofen, Mast, and Gans from Bern, where they looked at two groups. One group was treated by direct reduction, open direct reduction and a bone graft, and the other group was treated by indirect reduction without the graft. The numbers are about the same. The reduction of the medial cortex was done in about half of the cases. Here it was not done. The use of a tensioner was about a third was done. Here almost a 100%. Those were with a 95-degree angle blade plate. And so on. You see, time of surgery was about the same. There was no antibiotics and no antibiotics. I don't know if that is correct to go without any. I think today it's actually the rule to use them. And the infection rate was nil in the closed method, indirect reduction, without bone graft. The time to healing was quicker. The time to full weight bearing was also much faster. So I think this paper, although retrospective, showed very, very nicely that biology has to be kept in mind and is of a very big importance in these fracture treatments, not only for intertroch or subtroch fractures, but also for all the others. And today, I think with locked plating devices, MIPO can be done even better, even easier, and should even improve these results. Here is a 52-year male, a skiing accident of Christoph Sommers. He was rather complex proximally in the trochanteric area, so he decided he would use a reversed Liss plate. He had to bend the plate a little bit, about 20 degrees, at the level of the fracture, so that it would really snugly fit to the bone. This is intraoperatively, nice reconstruction of the comminuted area. And this is at 3 months on the left and at 11 months on the right. This is an option of how to use a locking plate without having the disadvantages of the large screw of the DHS or DCS, and yet have a fixed angle device, which is easier to apply than a 95-degree blade plate. Another case of his where there is a fracture of the neck, and he didn't want to interfere with that by introducing a nail in this situation, so he chose again this kind of plate without touching the comminuted area in the subtrochanteric part, just bridging. And note the few screws he uses, those are all locking screws, and this is a beautiful result after 1 year. Sometimes there are also drawbacks. I show you this patient here. Please note that he had a nice reduction and everything, and he had a lag screw here. He wanted the plate to be taken off, and he had a new fall skiing, and he actually produced a stress fracture through the hole of that original lag screw at that level. This time it was considered more appropriate to use a nail to fix it. It took a long time to heal, and probably it was not only the stress riser there, but also from the very first operation was some devitalizing of the bone, so that the biology was disturbed as well. Otherwise, this fracture would have healed much sooner. So whatever implant we use, nail or plate, we have to respect the biology, we have to respect the anatomy, and then we can get nice results. So what are the conclusions? Subtrochanteric fractures are very often high-energy injuries associated with polytrauma. It is typically a fracture of the young patient group, not so much of the elderly. Operative fixation is mandatory. I think there is no discussion about that. The options available are, in the first place, intramedullary devices, then bridging locked plates with MIPO technique, gentle reduction for simple fractures. Aftercare of nailing is less demanding. It is clear that the weight-bearing device has a better chance to survive multiple cycles of load bearing. And planning, of course, is required in view of the whole patient. Thank you very much.
Next is Lisa Taitsman, and she's going to talk to us about pertrochanteric femur fractures.
Many give credit for the classification and early discussions of pertrochanteric femur fractures to Coker, although there's lots of opinions about who really described early on these fractures. A lot of the literature comes from the late 1800s, early 1900s, and here's one of the quotes that I found. Fractura pertrochanterica of Coker. The line of the fracture begins at or near the lower part of the junction of the neck and shaft and passes through or close below the greater trochanter, dividing the bone in two parts, of which the upper is formed by the head, neck, and upper part of the trochanter. That's a lot of words, but the picture that follows is something like this. So here in the States, that's what a lot of us refer to as an intertrochanteric fracture, but in some of the writings is referred to as a pertrochanteric fracture. We all know and love the AO-OTA classification, and if we look closely at this, we look at the line between the greater trochanter and the lesser trochanter. These are the extra-articular trochanteric fractures, the 31 A's. And that simple fracture line here is referred to as a pertrochanteric fracture with either simple or multifragmentary. And the line between the two trochanters is an intertrochanteric fracture, here what we commonly refer to as a reverse obliquity fracture. Let's go through the words: per, through, inter, between, and peri, about or around. So again, the line that connects the greater and the lesser trochanter really is more of a pertrochanteric fracture, and between, intertrochanteric fracture, really the reverse obliquity that we commonly refer to here. So like most of these other fractures, we have to think about who the patients are, and like most of the injuries we see here, these are bimodal distribution of young folks with high energy injury fractures and geriatric older patients with lower energy injuries, but also we are seeing a growing number of elderly patients with high energy mechanisms and polytrauma, which poses the following problems. With these young patients and high energy injuries, we definitely often see a lot of comminution, we see lots of other injuries, and these patients may be very sick. We have to think about blood loss, timing of surgery, and prioritization of injuries. In the older patients, we're faced with osteoporosis as a big challenge, and some of our goals may be a little bit different, as mentioned earlier. Early weight bearing and mobilization is really a key. Worrying about arthritis 30, 40 years down the road in an 85, 90-year-old patient may not be the main concern. So what are the goals of our treatment? The goals really are reduction. That's really the key. I think Dr. Mayo said it on Thursday in the conference. A lot of these fractures you can treat however you want. You just need to make sure you get them reduced and then stably fixed. And it may be a little bit dealer's choice how we get there and how we do that. But our real goals, as we just heard before, is restoring the anatomy. And that's the functional and mechanical anatomy in terms of length, rotation, translation, which is often missed, neck shaft angle, and version. We really need to avoid varus with these. I think that is one of the early predictors of failure. The implants, I think we had a really nice overview in the last talk about the various implants that we can use. There are plating options and there are nailing options. I think we should all be comfortable with both, and in different fracture patterns, may be pushed more towards one or the other based on patient factors, fracture pattern, fracture issues, and what you're more comfortable with. But the key is to get a reduction and hold it properly with the implant. I think this was doomed from the day it started. Was this fracture ever reduced? Who knows? And maybe the inappropriate implant was used, put in an inappropriate way to help maintain and obtain and maintain control of this fracture. So let's start with an example. This is a 35-year-old male who was involved in a motor vehicle collision. He had multiple injuries, really almost every system involved. He had the fracture that we see here, as well as many other same-sided acetabular fracture, an open pilon fracture, and he was taken fairly urgently to the operating room to deal with some of these issues. When we took him, here's the fracture we see. It's a very comminuted fracture involving the trochanteric region. He also has a shaft fracture a little bit further down to deal with. Given his situation, we elected a to use more of a nail-type fixation to achieve a reduction in a percutaneous manner using a bunch of pushers. In my hands, I didn't think that opening up this fracture, I had anything that would give me a more anatomic read than I could get radiographically. Using hooks, using a nail, minimizing blood loss, putting an implant like this in, and then 6 months later, here he is. This is another patient, similar issue, but we see with these sliding hip screws, these medullary hip screws, that we do have some issues with shortening. When I saw this, I sort of said, oh, there's something about this femoral neck fracture. It looks impacted. I don't really know that there's a perfect solution to these injuries. And I worry about the long-term outcome and the long-term healing and getting this thing to union. He, too, is a patient with multiple injuries, but a very difficult fracture, at least in my opinion, given the impaction and the comminution in the femoral neck area. So for him, too, I selected this implant, the medullary hip screw. Not to give you the same thing over and over, but we saw him with some early healing, but with some collapse and some shortening, really. And over the 3-month and then the 9-month period, here's where he is. He had a lot of pain, actually, from the tip of the screw, that the blade that stuck out, but we were still seeing progressive changes on his radiographs. So I elected to shorten that, and he actually did quite well at his 2-year follow-up. I think the DHS has been an implant that a lot of us have known and loved and is tried and true. But here's an example in the other direction where you just really have to pay attention to detail and be careful, because not every implant solves every problem, especially if not done correctly. This is a 27-year-old man who was involved in a motorcycle collision. This was his injury. Don't know if you want to call this a pertrochanteric fracture, a subtrochanteric fracture, or a reverse obliquity fracture, but a fairly transverse fracture, really kind of at the base of the proximal segment. He was managed initially elsewhere, and he received this as his treatment. And I think I just want to show this, for example, for people who aren't as familiar with actually dealing with these injuries, so we can start really looking at some of the issues and the subtleties or not so subtleties of reduction in implant selection and putting them in. So if you look on this, on his lateral x-ray, we see the translation of the reduction, right? There's one piece, there's the other piece. So this is a fracture that really has not been adequately reduced, even though on the x-ray on the left there, the AP kind of looks like he's neck shaft angle may be reasonable. I think for those of us who have looked more at these know that there's clearly something wrong, and it's not a perfect reduction, but I think this shows it better here, where this is a fracture that's really off. Also, the implant, there are some technique issues in terms of implant placement, as an aside. So how do you treat something like that? I think it's really important, instead of waiting till that fails, we get a better reduction, we anatomically reduce it with an open reduction, able to clamp and provisionally fix it, and then go on with a different implant. Again, I think at this point, almost any implant would work on this fracture now that it is reduced and clamped. We elected just to find new paths with a reconstruction nail. Hopefully we improve his chance of better long-term function. So this one here really is a fairly vertical femoral neck fracture with a large trochanteric component. And that's exactly how he managed this injury. With an open reduction, pieces that weren't comminuted to the extent that he wasn't able to get an excellent anatomic reduction, and then hold this with plates, including a plate in the anterior inferior aspect of the neck, and then the proximal femoral locking plate. He had the good fortune to see this lady 5 years later and have this result and this x-ray demonstrating a little bit of flattening of the head, but overall an outstanding result for what is a very complex problem, especially the femoral neck, where we know there can be trouble healing in young people. Just for completeness' sake, I also want to look at the other types of implants. You saw some good examples in the prior talk. This is probably more of a reverse obliquity, a proximal femur fracture in this pertrochanteric region. And this is a 42-year-old man with a bicycle accident, this comminuted type of fracture. Given the fracture, I elected to use a blade plate, get the anatomic reduction, do this indirectly in terms of not keying in every piece, leaving the medial bone and the medial tissues alone, trying to restore the proper neck shaft angle, the appropriate version, and fixing him with a plate. Fortunately, I don't have any long-term follow-up on him. But that's where he was shortly after fixation. I only bring these up because these are old challenges, these reverse obliquity fractures that we know have had problems, and we know there have been some poor implant choices for these fractures. But over the years, we tend to see these patients and these failures keep popping up. So I do think they do merit addressing and discussion. These reverse obliquity fractures, it's very important to recognize the pattern, and I think it can be challenging. I think traction films can help, but I too have had the fracture I thought was a simple intertrochanteric fracture, and really only in the operating room when I'm really studying it again with good traction do I realize that it's much flatter or more of a reverse obliquity type pattern than I previously thought. And in most of these cases, a simple DHS may not be the answer. These are patients all referred to us within the last few years with the same type of a problem. A reverse obliquity fracture, something trending more to a subtrochanteric fracture, where I don't think the fracture line has been appropriately identified, and a DHS has been used in a situation where the fractures continued to displace and these have gone on to fail. I think there are times when it can be used. It's a very powerful implant, but I just think it's important to understand these fracture patterns, and then in some of these cases, a different implant may be the most optimal way to manage them. It's a lady I took care of a few years ago. Here's where she had started. They watched over some time as this started to fail. Again, not quite sure that this is the most appropriate implant given the fracture pattern. And we were able to revise this with a blade plate, and she went on to do well. So in short, what have we talked about? There's lots of types of fractures of the proximal femur. Some are almost unclassifiable, and you really just need to describe what you see and where the fracture lines are and the areas affected. It's important to really try and understand these fractures so that you can better reduce the fractures, hold the fractures, and then fix with an implant. I think there are a lot of variety of implants. I don't know that it's very clear that there's really true one right answer for any one fracture, but I think it's important to try and pick the one or two implants that may work better for a certain fracture, and then make sure you use an implant that works in your hands after a good reduction and good choice of implant. Thank you.